With the Moores, we will be there within the hour, and you guys distinguish what happens. The behavioral health urgent care is located in Pequay and soon to open is our facility-based crisis. So there are different ages for each service. So with the Moores, we assist children from 3 to 20 years old. With a call from the parent or caregiver, the team would be there within the hour to assess. Health urgent care, ages 5 to 20 years old, walk right in and be assessed by a clinician. So we use that as an alternative to a hospital emergency department. So if you bring your child to a hospital emergency department, it could take days, hours, it could longer, just to be seen by someone with the possibility of them knowing something about behavioral mental health. So with the behavioral health urgent care, you could go right in and speak to someone, a licensed clinician, and discuss it with exactly what's going on. And then the facility-based crisis units will be for children 6 to 17 years of age. Those are not opened at this time. We're hoping very shortly. The facility-based crisis unit is the only units that would be Alliance Medicaid specific. So those are specific to Alliance Medicaid recipients from 6 to 17 years of age. The behavioral health urgent care and the Moores, regardless of insurance, regardless of the if you're insured or not, regardless of the policy, we will be out there after that call. And if you're if you walk into the behavioral health urgent care, we will not close our door to anyone. So no matter which provider, you will be assessed by the clinician. So with the Moores is a mobile outreach response engagement stabilization. So it really depends on the level of care that your unit would need. And I say unit because it's not always the parent. It can be, a lot of the children being seen are in foster care. A lot of the children being seen are staying in the buildings of DSS. We have a lot of children coming from public schools. So it really depends where they're coming from and what that unit is going to look like. Sometimes it's that case manager, sometimes it's a foster parent, sometimes it's that parent. But to activate the Moores service, it would have to be a parent or caregiver to make that phone call. We can use a referral from an adult that wants to advocate for that child, but the quickest way to get that Moores established would be for that parent or caregiver to make that call. After receiving that call, we're going to speak with you and be there within that hour. That could be for Wake, Durham, Orange, Johnson, and now Garnet County. So this is not just a Wake County specific service, okay? So if the team does get out there and they're assessing that child and seeing what's going on, and they feel that speaking with a clinician would benefit that child and getting further resources and assessment, then they would refer you to that urgent care. So they are very intertwined. If you're using the Moores, it does not mean that you cannot use the behavioral health urgent care. Okay, so a lot of times you're involved with the Moores, and you might decide, I'd rather go in and speak to the actual clinician to see what's going on. So with the behavioral health urgent care, you would go in, fill out the paperwork. Once you're complete and the clinician's ready, you would go right in and speak to that clinician. Okay, so in essence, when you walk into a hospital emergency department, there's a lot of chaos, there's a lot of extra trauma, there's a lot of people that know about your physical health and not about your mental health, okay, because they are separate and your mental health is just as important. So you really want to make sure you speak with someone who knows exactly about behavioral and mental health. So once that clinician's ready and the family's ready, they would come in and speak with the clinician, and from the start, the clinician's already trying to think of resources that would benefit this unit. And when I say unit, because these resources are not always going to be catered to that child. All these services are extremely family-centered. So you're not going to stabilize a child and then send them back into the same home or unit if the unit isn't stabilized. So if the parent or caregiver is the one who needs the resources, then that's where the resources are going to go. Okay, so it is very family oriented, very family centered, and it really depends on what's going on inside that unit of where those resources are going to go. So when the clinician is speaking to that child and the unit, they're going to distinguish if that child would benefit from additional assessment and observation. And if so, they would be admitted into that behavioral health urgent care for an up to 23.99 hour of assessment and observation. Now, 80% of the children walking in are leaving within 3 hours. They do not need that additional support of assessment and observation. So they're walking in, being assessed by the clinician, meeting with a family partner. A family partner is someone who is close to a peer support. So I don't know if you guys are familiar with a peer support, but a family partner has to have that loved experience of loving someone with a behavioral health or a mental health concern. So they have that compassion, they have that empathy, they have that understanding. To me, it's kind of like the bedside manner of doctors. They can walk you through it, guide you through, and get you where you need to be. So the behavioral health urgent care, as I said, about 80% are walking in, meeting with the clinician, meeting with that family partner, and then leaving within 3 hours. Okay, that family partner is going to wrap around, connect with you again, stay involved, and make sure that you are handed off the resources that you need to thrive in the community. The goal of each service is really to connect you to the resources you need in the community so we can reduce hospitalizations and out-of-home placements when necessary and possible. So when inside the behavioral health urgent care, if you are getting close to that 23.99 hour mark, then you would be moved into the facility-based crisis unit, which would be for an up to 2-week stay. So since we are partnered with Alliance, and we already know that the facility-based crisis unit, which would have 16 beds, would be focused on Alliance Health Medicaid for the first year. We also have additional supports for Alliance Health Medicaid recipients. So although the Moores will go out every call, with Alliance Health, we would be able to stay involved and maintain that relationship and almost as a care coordinator and remain involved for up to 8 weeks. So that is with Alliance Health Medicaid. Other providers will get that support from the family partner and connect you to the resources that you need. But with Alliance Health Medicaid, we remain involved for up to 8 weeks being a care management support. So WellCare has signed on for 4 weeks as well. So with WellCare, you would get that additional support as well. Regardless of which service you use, you will be leaving with the support of the family partner. So they will connect you to those resources and get you, advocate for you when needed. Okay, so you will have access to those family partners, email, calling for an amount of time, depending on which service. So that is the Moores. So regardless of insurance, regardless of, and I also want to stress with the Moores, a lot of people consider the mobile crisis. You know, we have to call when there's that peak of aggression, the peak of crisis, we're fumbling, we don't know what to do, there's a sense of urgency. With the Moores, if your instincts are telling you something is going on, then that is the time to call. If we can assist that child before they reach I would say the peak of crisis. I know the clinician probably has better words, but I consider it the peak of crisis when you know it's elevated, you're already there. And if we can assist any child before they have to get to that point, it can only benefit the family, the child, everyone. So I always say if you're going to call the police on your child because of a mental health or a behavioral health concern, the Moores is a great alternative. And the queen of anxiety at 50 years old, and you put a cop car behind me, my elevation of my anxiety is going to elevate. Now just think of what you're doing to a child who's already in crisis, okay? So if we don't have to involve the police who already have enough on their plate, they're handling a lot. I know CIT has been amazing with them, learning about behavioral health and how to answer calls with behavioral mental health concerns. But if you can get a behavioral health provider right out to the location instead of a police department and ease that anxiety of that situation, of that crisis, and ease that trauma, then you're only going to benefit that child. So if the Moores is a possibility for them, it's a great resource as an alternative to calling 911 on your child. If you're going to bring your child to a hospital emergency department, then the behavioral health urgent care located in Fuqua is a great alternative. Okay. So with that being said, you know, we don't determine what your crisis is. We are seeing a lot of children, anywhere from usually 7, 8, 9, a lot of depression, a lot of anxiety, a lot of children on the spectrum trying to get, you know, the resources that they need to remain in the community and to thrive. And that's really what we're here for, is to connect you to the resources that would help your family thrive in their community. Okay. So We have our information over there. If anyone has any questions, they will be answered at the end. You can always reach out to me if you have questions regarding the service. But I really appreciate your time and having us here. So thank you very much.
Do you want me to go through some slides of where do
It
we?
wasn't moving, so I was
Oh,
going
okay.
through anyway.
Okay, all right.
As I said, the Moores will go out to Wake Johnson, Durham, Orange, and now Harnett County. And anyone in that Alliance Health catchment area could go to the building. We're not going to turn on our, right there is really what I was talking about, but it's a crisis for a child. We don't distinguish that. So your intuition and your instincts are telling you, and if you see your child isolating themselves or maybe going with a different group of friends, or you're hearing, phrases that they're saying that your mind is saying what is going on, maybe there's bullying, maybe they're school refusal. So it really depends on what that situation is to make them want to go. That is the magnet for the Moores to initiate the Moore service coming to your home or your location. We've met people in the library, we've met people in the park, we've met a lot of people in parking lots across from their schools. The first thing that happens if there's a behavioral health concern in the school, that child is discharged, right? They're going home for the day. So although we're not allowed inside the schools, we have a lot of parents calling to meet us at the school parking lot so we can assist when that child is leaving the school. Otherwise, we'll meet them right in their home on their doorstep, right, so we can be there when they arrive. So there's many ways to connect. Wherever you're comfortable, we will meet you. We have magnets on the side as well. So if you have families that could benefit from that Moore service, give them a magnet, take a picture, put it in their phone. That way, if there is a concern, they could call right away.
I'm just gonna slow.
There is one picture.
Okay.
We do have Oasis. So those are the bedrooms for the facility-based crisis. It's a beautiful setting. We really want to make sure that the child is seen as a child. We want them to feel comfortable, feel seen, keep their dignity. This isn't a place where they're just going to go into a unit and sit there. The real main purpose is to engage the child as much as they can. And if that means on the basketball court, that means going outside. We had a child there a few weeks ago. It was pouring. She was in the urgent care and just needed to go outside and feel that rain. And that's what we did. We went outside and we hung out in the rain for a little bit because that's what she wanted to do. And it's really a place to engage. We're not going to build that rapport with the child and learn what's going on if we're not engaging. So we are as much as possible, hands-off facility. We do utilize Ukiru. It is new to North Carolina. We are a pilot program, so it is a lot of pads and redirection. So if I know that Dana likes to kick when she gets frustrated, we do have Ukiru mats all over the building. And if I'm going to engage with her, knowing that there's a possibility that she can either harm herself or me, I can grab an Ukiru mat and engage. So really our purpose is no matter what, we want to engage, see what's going on and get to the bottom so we can connect you to the resources. We do utilize Oasis. A lot of people, Kids Peace has established Oasis. A lot of people know it as like those calming corners in schools. Just really a safe place where you can relax, get out of the unit. That is our behavioral health urgent care Oasis. So it's really a place where they can bring in different sensory items and focus on a different sensory. We have carts that they could bring in, everything from smelly lotions to coloring, to musical instruments. So really depending on the age appropriate items, but it's really a place that they could get off the unit and relax. So that is the Hope Center.
Good afternoon, everyone. My name is Dana Heuser, and I'm the Director of Business Development at Raleigh Oaks Behavioral Health. I also have Wanda here. She is our Director of Clinical Services at our facility, so she will speak a little bit more to the clinical aspect of what we do. We're going to talk about today mental health crisis in adults. So our facility serves patients 18 and over. So we'll talk about what is a mental health crisis, what role can you play if you know someone who's in crisis, We'll talk about hospitalization for mental health crisis, and then again, how to prevent a mental health crisis if you know somebody has a mental illness. Next slide. So what is a mental health crisis? According to the National Institute of Mental Health, 1 in 5 adults are living with mental illness. We know this. And according to NAMI, a mental health crisis is any situation which a person's behavior puts them at risk of hurting themselves or others, and or prevents them from being able to care for themselves or function effectively in the community. So mental health does not discriminate against age, race, gender, religion, employment status, marital status. It can impact anybody that you know, including yourself. So keep that in mind while you think about who could be in a crisis. Next slide. Signs of a mental health crisis. So mental health crisis, when somebody goes into a crisis, it's often triggered by a stressful event. Not always, but that's certainly the majority of the time what's happening. So what are some signs that an adult might be in mental health crisis? They might not be keeping up with normal daily tasks. So you might notice they stop showering, they stop cutting their hair, they stop really taking care of themselves, doing some of those things that we might call self-care, but really just any type of hygiene. That's important to take note of. Maybe they're getting really easily agitated on things that didn't used to agitate them. We can't say what should agitate someone, but if you kind of know their typical anger stance and all of a sudden they're getting very short and angry at things that didn't irritate them before, that's certainly something that you need to keep in mind. Rapid mood swings. So if they're very, very happy one moment and then very mad or upset or angry the next moment, that could be a sign that they're in crisis. Delusions or hallucinations. So we see this both auditory and visual. So these people might believe that their brother is the president and this is their truth and they believe that. And so that's something to keep in mind when you're speaking to them. Wanda can talk a little bit about that, but you're not going to reason someone out of a delusion. So you need to make sure that you're speaking to them appropriately. Extreme withdrawal. So again, they're sitting in their room, they're not coming out, they're not talking, they're not socializing, they're not being themselves. That's something that could be a sign of mental crisis. And then changes in eating and sleeping patterns. So maybe they're sleeping all day, maybe they're sleeping for an hour a night. That's a red flag if they're typically not doing that. And then eating, if they're, again, eating a lot more than they normally would, or if they've really cut down on their eating, that could be a sign of crisis. Next slide. Okay, so what do you do if someone's in crisis? Let's say you've identified that your friend is really withdrawn and she's sleeping all day long. Remember that a person who's in crisis or headed towards a crisis is a threat for themselves or for somebody else. So a lot of people who are in mental health crisis want to either harm themselves or another person. So the number one thing to do is create a safe environment for that person. Safety is key here. You want to limit stressors. So if you know something really, again, irritates that person or kind of sets that person off, remove that from the situation. And then remove anything that could be used to cause harm. So our facility is a psych-safe facility, and we make sure when patients go to the units, even things like shoelaces, that's not safe for a patient who's thinking about hurting themselves to have. So really think through what could this person use as a weapon on either themselves or somebody else, and try to remove that from the situation. And then call for help. So 988 is a crisis hotline number you can call, and obviously 911 if that person is about to harm themselves or someone else. As Michele said, she spoke about the behavioral health urgent care for children. There are a couple of behavioral health urgent cares for adults as well. I know Monarch is one of them, located in Raleigh, not too far from Raleigh Oaks. But again, 911 is always your safest bet if you don't know where else to take that patient. As Michele said, the ED is not the best place for a patient. So if you have a different place to take them to that's safe, that's always better. So again, an urgent care is an option because a behavioral health urgent care, those clinicians are trained to care for people in mental crisis. And then you can also walk into an inpatient behavioral health hospital like ours. So I always coach people, I think the best thing to do is to call our admissions phone number and say, hi, my friend's going through this, and kind of describe the situation. Our assessment team is very good at knowing whether somebody is appropriate for inpatient care or not. We don't want to put somebody in our hospital if they don't need to be there. And so if they don't need to be there, they can give other options like a partial hospitalization program or an intensive outpatient program, which is multiple days a week for many hours a day, but it avoids that overnight hospital stay if it's safe for the person. So again, that assessment team can really tell you, yes, I think it makes sense to bring that person in, and they can even give you a time to bring the person in so that the person can then be taken right back for an assessment. Inpatient admissions for a crisis. So there are two ways that patients come to us. They either come voluntarily. So let's say you have somebody who, again, is willing to get treatment. They recognize they're in a crisis. Those people can come voluntarily. We also accept patients who are under what we call IVC status, which is involuntary commitment. This happens a lot of the times when a patient is taken to an ED and they are refusing treatment. So often, again, I said earlier, it's hard to reason sometimes with people who are in mental health crisis. So if you're trying to reason with somebody and they're saying, no, I'm not willing to go to treatment, I'm not in crisis, if they are a threat to themselves or society, that's when they get put under this involuntary commitment status, and then we'll receive the patient from there. Any patient that is sent under IVC status, that means that the patient needs to come via sheriff's office. So that's something to keep in mind for safe transport. The patient needs to come from the ER to our hospital in a sheriff's car. If you are with somebody who's willing to go voluntarily and you can get the patient safely to us, that is an option to take as well. But if you don't feel comfortable with that, then obviously it's always best for law enforcement to get that patient to our facility. So our what we call door to floor time, so when the patient walks into the building to the time that they're on their unit, is typically less than 2 hours. And we try to even cut that down to about an hour, but we need to go through a full assessment with them, including a nurse who meets with them to go through their medical history and current medications and all of those things. So it does take a little bit of time to really fully assess that patient. Part of that process is the assessment team looking at what the ED notes had said about the patient and kind of comparing that, making sure that things all check out. We have a lot of checks and balances to make sure that the ED is sending us what we need on the patient before the patient arrives to us. And then in admissions, the unit and the care team that patient will be working with are assigned to them at the time of admission. So if you're on, for example, we call our senior adult unit Team Wisdom. So if you're going on to Team Wisdom, you're going on to a certain unit within our facility, you'll be assigned that, your psychiatrist, your case manager, and your therapy team at the time of admission. Next slide. Okay, so I'm going to let Wanda talk about programming and the schedule for hospitalization.
Hi. Our business director did not need me today. She actually went through all of this clinical pieces very well. But I'll just add a couple of comments if I'm allowed. I'm Wanda Crawford, and I'm the director of clinical services at Raleigh Oaks Behavioral Health, and I'm excited to be here. Because one of the things that we've tried to do and that we are doing is changing the paradigm. We're changing the way people look and think about mental health, changing the way people think about a possible stay in a psychiatric facility. Let me ask, how many of you understand that there's stigma related to mental health? Yeah. How many of us also understand that God created us as feeling beings who happen to think? Yeah. Sometimes we're taught the opposite, that, you know, you're thinkers and you're thinkers and you're thinkers, and how many of us know that thinking leads to a lot of issues. A lot of the stress comes from the way we think. Because in our society, everybody is attaboy, attagirl if you perform well, if you think well, if you make high marks in your math test and your English test, you are a go-getter, right? But if you're intuitive, where you're really focused on your initiative and really involved with how you think and how you feel about things, sometimes that's not given as many kudos. Okay, with me? What we try to do at Raleigh Oaks is validate people's emotions. Because what happens, to Dana's point, crises come about when people don't really know how to handle their emotions. How many would agree with me that in our society, in our world, we are almost afraid of emotions? You ever seen somebody start to cry? What is the first thing you do? Yeah, push that up. I have a 20-year-old son who's a freshman in college. Thank God, as he was growing up, you know, I have a daughter and son. My son was growing up. He would say, "It's okay, get up, rub some dirt on it. You're going to be okay," right? Our daughters, we do a little bit different. "Oh, honey, sweetie, come on, let's talk about it." We encourage them to talk. Not saying I'm generalizing because this is not true for everybody, but typically this is the way it goes sometimes. So I'm supposed to be talking about group therapy and recreational therapy and cognitive behavioral therapy and cognitive processing therapy. But I just want to kind of wanted to put just like a human flavor to it, because everything starts with relationships and connection. When people are in crises, yeah, 911 or the 988 crisis line. But I find it more beneficial and more helpful if I can talk to somebody who I know cares, right? People, suicide, they say suicide is the 10th leading cause of death in our country. I would say post-COVID is probably higher than that. There was a study done by Dr. David Wood out of the University of Memphis, and he studied people who committed suicide off the Golden Gate Bridge. And one person happened to jump and he survived. And Dr. Wood asked, "So, what could have actually stopped you from jumping?" The gentleman said, "While I was on the bridge, people walked up to me. They asked me to take pictures of them by the name. Nobody asked me a question. Nobody asked me what was going on. If one person would have said, 'Hey, bud, hey, dude, what are you doing up there? Let's have a cup of coffee. Let's have a conversation,' he wouldn't have jumped. Why? Because we're hardwired for connection. We're hardwired for connection. We hear that all the time in church. That's why, you know, get up and say hello to the person to your left and say hello to the person to your right. Give everybody a nice hug. But when that person starts to cry, we might want to hush them down. I say let them cry. It's not them, it's us who are having a level of discomfort. So at Raleigh Oaks, we offer group activities and recreational therapy. Currently we have 2 licensed recreational therapies that will engage our patients in activities, whether that's playing a board game, whether that's playing card games, whether that's get up and moving and dancing and having a great time. We have folks to be able to facilitate that for us. Group therapy, these are your licensed practitioners, licensed clinical social workers, licensed clinical mental health counselors who actually run what we call our processing group. This is where you'll see the CBT or cognitive behavioral therapy. It is the go-to, it's the gold standard when it comes to treating disorders like anxiety or panic attack or, you know, depression. Cognitive processing therapy is a 12-step program, not a 12-step program, a 12-session program. We have those 2 12-step programs. A 12-session program typically focused on folks who are struggling from post-traumatic stress disorder. It's a processing group. Mindfulness, of course, it's really all about teaching us how to stay focused when your mind is full. Being in the room where a lot of activity is going on, but you're actually still able to center yourself, whether through diaphragmatic breathing, focusing on an object in the room, like I'm focusing on Michelle right now. Thank you for having us, by the way. That would be mindfulness. Solution focused therapy is really about, tell me if you woke up tomorrow and things were different, what would that look like? Looking for those actual tangible solutions that would help you move from point A to point B. Mental health or mental illness or mental impairment is really about those items that actually impair my daily functioning. So please, when somebody's coming in and they're sad, don't call us for somebody being sad. Actually have a conversation. We look for frequency, duration, and intensity. How long has a person been sick? 2 years ago, I lost my big sister. She had a stroke and she just couldn't recover. 2 years later, I'm still kind of sad about that. But I'm able to get up and I'm able to go to work. I'm able to function. If 2 years later, this is a gross exaggeration, if 2 years later I'm not functioning, I can't manage my daily living tasks or skills, I can't hold a conversation, I can't feed myself, those kinds of things, then I have a major issue. Sometimes grief grips people and it manifests and it shows up in different ways. We want to make sure that we're not rushing to judgment that a person is struggling with clinical depression when they could be grieving. We don't want to make rush to judgment that somebody is post-traumatic stress disorder when they have just witnessed a traumatic event. It doesn't necessarily have to be a service member who has been to war, like my husband is deployed probably 20 times out of his 30-year career. Doesn't necessarily mean that he's struggling with post-traumatic stress disorder. If he's able to get a good intervention and help him cope, could be just grieving. Or a lot of our service members that are coming back could need a good 8 hours sleep. That sometimes helps. So as to Dana's point, we try to make sure that we do and provide a thorough assessment for people that are coming. And our psychoeducational groups are just that. Our nurses facilitate those as well. We have even behavioral health techs that can facilitate those too. The next one. Prevention of the women talk about. Follow treatment plan. Whose treatment plan? Your treatment plan. Our treatment plan. We need to develop our own treatment plans, right? As people who are in charge of our own mental health. Having the conversation, and I actually think this is pretty amazing, pretty cool for your church to actually sponsor this, because mental health is a stigma. And sometimes in church, you know what we do? Let's just pray and believe. Let's just take it to the Lord. I'm taking it to the Lord, but He tells me if I take one, He's going to take 2 steps, right? So I'm going to do that. He requires me to do something. If not, it's just going to lay dormant. So your treatment plan is yours. If you're in our facility, we help you develop that treatment plan. Our whole program focus is patient-centered. It's really about the patient, the person in environment, deciding and determining and actually driving what happens to you, right? I'm the new DCS. I've been there for about 8 months. And my philosophy and my push is about empowering people that come to us. Dana alluded to Team Wisdom. Since I've been there, we've actually started to name our units. Team Wisdom is about those seniors who actually bring a wealth of knowledge, who actually can sit there with that person who's on Team Courage, who may be, you know, a 20 or 30-year-old person who thinks life is falling. And if you're 50 and over, you know that sometimes life falls, but you also can get up. There are also resources out there that can help you sustain, maintain, and get better. That sometimes we live in a culture now, everything's about everybody how they feel. You know, I'm going to do it because I feel like I want to do it. Sometimes it's not always the best course of action. We have Team Determination, our dual diagnosis unit. Those are folks who have primary mental health diagnoses, but also coupled with an addiction issue, whether that's alcohol or drug substance use. We have Team Restore. We have Team Restore. Those are for our most acute patients. Schizophrenia is one of the most debilitating mental health disorders out there. We don't know all the answers to it, but we know, as they talked about, the visual and auditory hallucinations, the dishevelness, the disorganized speech, the disorganized thinking. That's some of the symptoms that you're going to see in your schizophrenic population. Everybody with me? Yes. Practice self-care. That's really about self-awareness from my optic. It's about knowing what makes me tick, what bothers me, what irritates me, what makes me happy. It's all about self-awareness. We are absolutely capable of tapping into those areas for us that make us better. I like peer to peer. I'd rather talk to my girlfriend, my sister, and my best friend about something that's troubling me. My husband would call it a trusted agent, right? Somebody who you trust, somebody who you can share your confidence with. Be careful who those people are, right? Everybody's not a trusted agent. Choose them wisely and actually share and talk. And if people care about you, there's not going to be any judgment. They want the best for you. When you show up at our facility, or if you send somebody to our facility, what I guarantee you is that we have hearts of service. We're going to do our very best to take care of you. We're going to meet you where you need to. Treat your body well, eat nutritious food, sleep well, and stay hydrated. All of those things are important to mental health. Your mental health is health care. Also, be mindful that most change, any change, is going to come through pain. Even if you look at your walk with the Lord, it actually came through realizing that I need Him in my life, right? So when it comes to mental health, it's going to come where I need something different. I need some help. I need some support. Are you with me?
Last one.
She doesn't want me to talk.
Okay, the last slide we have is a crisis response plan. So if you know somebody who has a mental illness and you know that they're at risk for going into crisis, when they're in a good place, you can ask them to help write this crisis response plan. And this is similar to if you had diabetes or you had a heart condition and you wore a bracelet that said, I have this. This is similar to that, what to do if somebody who has a mental illness enters crisis stage. So this, you can talk about warning signs. So if the person typically gets really angry or really happy all the time and doesn't really show a change in mood at all, and they're happy consistently, maybe that's their warning sign. If they start being short with people, so they can kind of list what's an indication to you if they're going into mental crisis. And then things that they can do on their own. This is a reminder to themselves. If I start kind of going into this place, what are the things that I can do to try to get myself out of it before it hits the true crisis? And then my reasons for living. Again, people who are in crisis tend to have the want to hurt themselves or others. So this is really a reminder to them of why am I here and why do I need to continue living? And then social supports, they can list friends and family members that you can call and say, hey, John's going through something right now. Can you give him a call? Can you reach out to him? Make sure he's okay. Just again, somebody that you trust, that you can lean on and really have those tough conversations with. And then professional support. So you can list the crisis hotline there. You could list the therapist phone number. That's a really good idea. If people tend to go into crisis, you can call the therapist early on and say, hey, I think John needs a session sooner rather than later. I've noticed some signs that he might be struggling right now. So that's just a suggestion for, again, helping somebody who tends to go into, or who has a mental illness and might go into crisis mode. This is a way that you can kind of track everything, and that, again, they have that resource too if they feel themselves kind of slipping. So that's all I have from my side. Okay, so the first question is, do you have an education program for assisted living facilities? And are there grief support groups that will come into assisted living facilities for widows and widowers? So that's a great question. We work a lot with assisted living facilities to educate them on what might be a crisis and how to help those patients. We do know of psychiatric groups that work with those facilities that come in and assist those patients. So that's probably the best route to go, is to have, you can, if you have any other opinions on it, but I think the best route to go is to use one of those psychiatric groups that actually manages the psych care for that facility. Because again, most of the people on the staff at an assisted living facility know about healthcare, right? They don't necessarily know about mental health care. So they typically outsource that, not to say that none of them do their own psychiatric care, but that's typically what they do, is outsource it to a third party. And that's what I've run into in a lot of the assisted facilities that I visited. But we do try to educate them if you have a patient who, again, these things have kind of changed for them. They're not eating, they're not sleeping, they're sleeping all the time. Call us and let us talk through that with you so that we can decide whether the patient needs to come in for an assessment or if there's a lower level of care that the patient could benefit from. And then the second question is, does Hope Center offer, okay, so does Raleigh Oaks offer financial assistance for patients without Medicaid, self-pay, private insurance? Yes. So we have, all hospitals now are required by law to have self-pay rates for people, and we always work with them. We have a financial person on staff who helps with payment plans if the person can't make the out-of-pocket payment. So that's certainly always an option, and we want to help as many people as we can. Beyond that, we also accept Medicaid, Medicare, and all of the major insurances. We're in network with them. I don't know if I would call it a benefit, but one of the things that we learned through Raleigh Oaks, we opened in August of 2022. So we're less than 2 years old. We're a newer facility. And when you open a brand new facility, you're not in network with any insurances. And so we went through what we call single case agreements with a lot of our insurances. And so the benefit for that is our team now knows how to do it. And so even if somebody comes to us with a very, odd insurance that we've never heard of, we work with that insurance company to make sure that that person is getting the care that they need with us.
Yes, okay, so with the self-pay, as Dana already mentions, any facility is required to have cost for each service. So we do have self-pay scales for people who are uninsured or do not have the insurance that we are partnered with. So we would work with families for that. But regardless of the insurance, if you come in and we are not partnered with the insurance provider that you have, most insurance providers are going to pay and cover for that assessment of meeting with the clinician. So that's usually something that's covered with private insurances and other insurance that we are not partnered with. So that is how we're able to assist so many. We tried the single case agreements. It was a little tedious with the Moores, to do it. We will do it. It was the families that didn't want to go further with it. So we're willing to. We're not going to turn a child in away due to insurance. So regardless of insurance, we're going to assist. So if 911 was called, would the police department refer to the Hope Center? Many police departments have been referring to the Hope Center. The ones that are working with us have been collaborating. So we are being known to a lot of the police departments. If you call 911, you're not automatically going to get the resource of the Hope Center though. So if you're in one of the catchment areas that have utilized us often, then you'll probably get us as a resource. I've reached out to many police departments and they're overwhelmed. So we haven't gotten that collaboration going as well. But so there are many that will, but not all of them. It's not going to be guaranteed. Do you use volunteers? We will be using volunteers, but we are very limited, unfortunately, since with HIPAA, you really have to be careful of who's going to come into the building. So with volunteers, they would go through the same screening as any employee would. So that would include background checks and all the same process as the training with volunteers as well. So they are selective who's coming into the building. We have many people who would like to volunteer outside of the building. Really the best way to assist us is really getting the word out there that there is a place to bring the children. we do many events. If anyone ever wanted to come along and do stuff like that, that is great. We can always use volunteers for that, or collecting items for the center. When they come in, a lot of the children don't have some clothes, so we do have a clothing closet. We have school supplies for them. So we also have, the sensory items are a huge hit. We did just get a grant for Build-A-Bear, so children have that comfort item when they come in, but that grant only stays so long. So there are ways of supporting us by volunteering to get, maybe stuffed animals or sensory items for the children as they come, or clothing. So there are ways. My card is out there. We can always connect further on volunteering. And then the other question was answered, but the question was, do we assist people outside of the Fuquay community? And yes, we will. With the Moors, again, we will go out to your location for Wake, Durham, Orange, Johnson, and now Cumberland County, Harnett County. And then for the building, we assist Wake, Durham, Orange, Johnson, Orange, Harnett, Mecklenburg, and Cumberland. Okay. Thanks.
Thank our speakers who spoke more than